Good morning. It's my privilege this morning to talk about something that I dedicated a large chunk of my Air Force career to, and that was the planning and delivery of critical care wherever and whenever it was needed. Now, critical care is the care of people who are in an unstable physiologic state, right? People whose life could change for the better or for the worse. You don't know what direction. And so this care is generally given in an intensive care unit. And this is a picture of a modern intensive care unit. And there's a great deal of technology that you can see at the head of the bed, which makes this an ICU. And that doesn't begin to picture what's available close by, a pharmacy, radiology, and so forth. So when you plan to create an intensive care unit someplace outside of a big hospital like this, it's very important to consider all of the functions that are available here and how it is that you can duplicate them. Now, Dr. Tom Scalea, a great trauma surgeon in Baltimore, used to tell us critical care is not a place, it's a state of mind. And that's very true. If you have the right mindset, you can create that bubble of critical care around your patient. And the Air Force doesn't have the patent on doing this, even inside an aircraft. This is a photograph from the crew that I run with now, and we're very good at delivering critical care inside an aircraft. This art and science is well developed. It happens thousands of times a day all over the country. The difference is giving critical care for one person at a time, for short periods of time, is well developed. What is a very different endeavor is to create an intensive care unit for multiple people sustained indefinitely. When you develop that capability, then really the possibilities begin to open up. To help illustrate this, we'll start with a story of Sergeant Dan Powers. And in our tent hospital in Iraq one night, he comes in with a knife protruding from the side of his head. And he was in surprisingly good shape, actually, considering this injury. He had some paralysis of the muscle in his face there, and a little bit of pain, but otherwise felt completely normal. And fortunately, this knife had skived along the bone and completely missed his brain, actually. It was millimeters, but it completely missed his brain. The bad news is that you can see it crossing the midline here, and it actually went through the carotid artery on the right side and into the carotid artery on the left side. That's the main artery that feeds your brain. This is a very unstable situation, and our neurosurgeons were able to take the knife out and get a temporary seal on there. Now, that bought him some time, but what he really needs is a permanent seal. That seal could rupture at any time, and of course, that would have fatal consequences. Now, to go in directly and do this would be possible, but this is the center of his brain, and you have to go through precious territory to do that, really with an unacceptable outcome. The elegant solution here is to go in through the blood vessels and fix the seal internally. But that is a very advanced technology. It certainly was not available where we were, but it was available halfway around the world. And so now this soldier, critically ill, on life support ventilation, needs to be in an induced coma. His blood pressure needs to stay in very tight parameters. He needs critical care. But that critical care needs to be able to move from where he is to where he can get the elegant solution to his problem. Now, let's step back for a minute and remember the Cold War. The early 1980s, this bipolar world that we lived in was surprisingly stable and predictable compared to the world we live in today, and that predictability was reflected in the way planners were set up to give medical care to casualties. A great deal of resources were focused on building large, field hospitals pre-positioned in Western Europe where we knew the fight would be, and if casualties couldn't recover within a month and be returned to duty, at least they were in stable condition to be evacuated in very large numbers. And while that was going on in Western Europe, events elsewhere were afoot. This smoke cloud you see here is rising out of the Marine barracks in Beirut after a terrorist put a massive truck bomb underneath there. Now, there were hundreds of people killed in that event, and it also produced casualties. Some were wounded, some critically wounded. Some of those went in a C-141 aircraft to Germany, where among those who greeted them was a brilliant young surgeon named P.K. Carlton. In addition to saving lives directly through his surgery, Dr. Carlton saw that the world was changing and saw that we needed to change our medical plans along with that. This is a picture of P.K. Carleton right here, and P.K. Carleton and P.K. Carleton. Dad was a bomber pilot and a hero in World War II. Son is now an F-16 pilot and had his own heroic stories saving troops in Iraq. But we're interested in the man in the middle, the general surgeon, P.K. Carleton. And here he is at the first exercise of a new capability. He realized that the logistical footprint for doing forward resuscitative care really could be trimmed down to backpack loads so that you could rapidly deploy the ability to do that. But the logistics of supporting people, of providing critical care after their resuscitation, is another thing altogether. Not so easy to do. So his idea was to put this in the back of the aircraft. Now, this had happened on an ad hoc basis on and off over the years, but to truly plan the capability and make the promise that if the surgeons can do their resuscitation, that we'll pick up that patient and provide that bubble of critical care, that's something else altogether. Now, there were a lot of priorities in the world, and we can look back and know how the Cold War ended, but that wasn't a foregone conclusion at the time, and so there were a lot of resistance to his ideas as he worked along. And unfortunately, another tragedy in a far-flung area of the world pushed his ideas over the top. In the aftermath of the Battle of Mogadishu, or the Black Hawk Down incident, the special operations planners, developed their wish list. What would they like to have should something like this come again? And General Carleton's ideas were right at the top of the list. And so suddenly these ideas finally had a sponsor, and overnight the Air Force was now the proud owner of Critical Care Air Transport Team, what we call CCATT. And when I refer to CCATT, I refer to the capability of a physician, an ICU nurse, and a respiratory therapist, along with their supplies and equipment, creating an actual intensive care unit in the back of an aircraft. Now, this required some special teamwork, right? These folks had to work together in a way they'd never worked together before, and to create this bubble of critical care. And as good as our folks are at critical care, truly they're not experts at working in the back of the aircraft. So another element of teamwork had to occur with the Aeromedical Evacuation crews. These folks are not necessarily current and focused on critical care, but they know how to work in the aircraft. So now our team is growing. But of course, this does nothing if the aircraft doesn't move, and so another level of teamwork had to develop, between the air crew moving safely from point A to point B, now with critically ill casualties in the back. And then the larger circle of teamwork, of course, was the airlift system that seemed to have an almost miraculous ability to make these big, beautiful planes appear out of the sky right when we needed them most. So now we're in the mid-1990s, and we have this capability. So in the tradition of General Carleton, the first thing we did was start to exercise it. And here we are, casualties, if we can flip back one, casualties on the ground, simulated casualties. Here we are with simulated casualties in the aircraft to keep our skills sharp. We have beneficiaries in those times all over the country and around the world who needed help. And this is an example of an active duty airman having a heart attack who needed to get to a cardiac catheterization lab. He was doing a drug interdiction mission in the Caribbean, and the system brought us this pretty Learjet to fly very quickly over the Caribbean to get him to a cardiac cath lab. Here's another one of our peacetime missions. Another active duty airman having a heart attack so bad that he could not come off of his heart-lung machine. And so his intensive care unit included, it was like an OR, his heart-lung bypass machine and a host of other technology running inside this C-141 as he flew 4,000 miles over the ocean to get to a heart transplant center and arrive safely. Now, in the mid-1990s, NATO became involved with a peacekeeping operation right at a critical time in this sort of test CCATT program. And we had to, go down there to Bosnia and take care of a number of casualties. This is a flight. We're on the ground in Tuzla Air Base, having just arrived in a C-130 that had attracted the unwanted attention from anti-aircraft artillery. I didn't know that still existed anymore, but it did, and they found us. So we made it down there to pick up a critically wounded soldier who was arriving in a Black Hawk helicopter, and the air crew managed to safely navigate the snowstorm, the threat, and we got this guy back into Germany, where he had an excellent recovery from what was a life-threatening injury. One of our earlier trips involved a soldier who had a skull fracture, an electrocution, a cardiac arrest, and very severe burns. And he needed to get from Europe to the Army burn unit in San Antonio, and he needed to get there very quickly. Now, this was an incredibly high-risk mission from a medical perspective at a critical time in this program, and if things had gone wrong, I don't know what would have happened. There were a lot of people who questioned that we should even be doing this kind of thing, but fate was on the side of the soldier that day and on our side, and he actually got off the aircraft in better condition than the condition he was when he got on the aircraft. We truly had an intensive care unit moving him forward in his care, and ultimately made it out of the hospital under his own power against the odds. In some ways, the CCATT program came full circle in 1996 when another terrorist bombing attacked now an Air Force barracks in Saudi Arabia, and now there were critical care transport teams available to fly in on no notice and take the most critical casualties back to Europe. They got better care, and the folks downrange now had their resources could be directed at a at the less critical population of patients. The world changed again on 9/11, and once again, who's in the middle of it but P.K. Carlton, now no longer a major, he's now a lieutenant general and the Air Force Surgeon General. And the teams that he had envisioned, and many of us had worked so hard to establish, were now up and part of the Air Force inventory. And as we went to war, the real test of this capability and the promise that we'd made was now under scrutiny. And to help illustrate how this works, we'll follow the case of one young soldier who was driving a Bradley fighting vehicle when they were ambushed by a truly massive bomb that went off underneath his vehicle. Now, his unit was able to evacuate him to a nearby forward surgical facility, and they stabilized some obvious fractures and moved him up the evacuation chain, where he was becoming progressively unstable. And within 12 hours, he made it to our location, the Air Force Theater Hospital at Balad Air Base in Iraq. Now, this is a hospital that was built for evacuation. For several years, we had been in tents, and this photograph was taken right before we moved from tents into this kind of modular design. And our helipad was down here, and the casualties would come in through the emergency department. Everyone got a quick once-over and stabilization, and then we had radiology. If they needed a CT scanner, they could get it on their way to the OR. Many people needed surgical stabilization, and then they could go to the ICU if they were unstable, or the ward. Those who were ambulatory went over to a staging facility, and at least once a day, a bus would drive in, and the litter patients would go in the back, the ambulatories would go out the front and out to the flight line and, and back into Germany. So this hospital, which ran very efficiently, was built completely around the concept of rapidly stabilizing people and moving them into evacuation. Now, for our young soldier, at this point, he's now in severe respiratory failure. His blood pressure is unstable. He's got multiple fractures, and this black area is his spinal canal, and it should be a full oval. This white in here are bone fragments. It happens that this is right at the level at which the spinal cord in many people moves into individual nerves. And so it's possible that he's not paralyzed from this. It's possible that the individual nerves have been pushed aside and maybe compressed by these bone fragments, but we don't know because he's still in a coma from the original blast injury. So in addition to all of the other ICU care that he needs, his ICU also has to not move his back around because these sharp bone fragments can paralyze him, permanently for the rest of his life. The Air Force had thought about this, and the solution we had available to us was this spinal transport bed. And here he is on the bed inside a C-17. We were able to, again, create a true intensive care unit for sustainable, comprehensive critical care. And I've practiced medicine in the back of a lot of aircraft, and there's none finer than the C-17 in terms of approximating that hospital ICU that I showed you in the first slide. And when he got to Germany and woke up from his coma, his legs did work. He got his stabilization and ended up having a good outcome. But he did that because we were able to create that bubble of care around him. Now, it wasn't always, this mission is not always about, roomy, spacious, well-lit C-17s. For in-theater work, the Noble Herc is the workhorse. And oftentimes, these missions are done at night, blacked out. You're taking care of multiple critically ill casualties with just a little pool of light for your headlamp. This photograph was taken during the daytime, but it illustrates what would happen. Now notice the horizon is here, right? The horizon is not horizontal. And so this is at more than a 45-degree bank angle. And this would happen, right? You're hunched over a patient, you're assessing them, you're giving medications with a little pool of light, and suddenly your entire hospital, if you will, does a bank angle to this side and a bank angle to the other side. So not necessarily good for the patient or good for you, but that's what it takes to get safely from point A to point B, and that's what our teams have had to adapt with. So this is a diagram now compared to that sort of earlier Cold War model of how the casualty evacuation works, and these CCATT teams plug in at multiple levels. And we're very proud. There's different ways that you can calculate the statistics of died of wounds or war wound lethality using a consistent method going back to the Revolutionary War as best as we can put together. You can see that the war wound lethality rate had kind of plateaued here in the mid-20s, and with Operation Iraqi and Enduring Freedom, there was really a dramatic down, and many factors contributed to that, but the sickest casualties all left the theater through our critical care transport teams, and so we can say that we at least contributed to this. And many people would be happy to say that we'd made that remarkable progress, but the next generation was not happy with that, and they want to know how come they can't get this to zero. And so now the visionary leader, here you see Colonel Iddens, who realized that when he went out taking care of these casualties, he could make a contribution by giving advanced care far forward. And so now the newest thing in the inventory are called TACETs, or Tactical Critical Care Evacuation Teams, which literally bring this advanced care far forward for the benefit of those casualties. And here are a couple pictures of these TACETs in action. It's not just combat casualties. Disaster victims need care. That was a 747. There are the casualties being evacuated with a joint team. International engagement, other countries have picked up on this. Chile and Bangladesh, we've worked with them, and hurricanes. We now have a formal arrangement with Health and Human Services to stabilize critically ill patients at airheads and move them out in advance of hurricanes. The technology has been commercial off the shelf, but now with military sponsorship, really cutting-edge devices are being made that integrate everything together. Back to our soldier with a knife in his head, he ended up getting his trip, got his seal made in his artery, and I got to run into him 6 months later at a conference, smiling, completely normal, and actually back on jump status. So it's been a humble privilege for me to be able to take care of these wounded warriors who have given so much for our country. And to make our contribution to bring them back safely. And we certainly couldn't do this without an airlift system that got us wherever we needed to go. So that's all I've got. Thank you.